are going to do another NGN case study today. I guess we all know about unfolding case studies by now. We have been doing them, several of them in our live classes together. We have lots of case studies in our question bank, which you might be, seeing them. The main thing about unfolding case studies are that you will be getting 6 questions from one case. Okay, I mean, one case can be just one patient, or one case can be like multiple patients. It depends on how they ask, right? This is the scenario which you have right now. A 28-year-old client with a history of schizophrenia is admitted to an inpatient psychiatric unit for acute psychosis. The client has been experiencing auditory hallucinations, commanding them to stay alert because someone else is watching or someone is watching, along with paranoid delusions that staff are trying to harm them. The client has been pacing frequently, sleeping only 2 to 3 hours per night, and has required redirection due to disorganized speech and agitation. Okay. 3 days ago, the provider initiated haloperidol to manage worsening psychotic symptoms. Since starting the medication, the client has become less verbally aggressive and has also appeared increasingly withdrawn. During the morning assessment, the nurse noted that the client is having auditory hallucinations, is diaphoretic, has flushed skin, and reports feeling very stiff and unable to move comfortably. The nurse also observed generalized muscle rigidity with a shuffling gait. Vital signs: temperature is 102.6, heart rate is 118, blood pressure is 168/96, respiratory rate is 24, oxygen saturation is 95% in room air. The client has decreased oral intake since admission, and client had minimal urine output overnight. All right. So you might be feeling like it's a lot of information, which is true, but it might be even more when you get the actual case studies. Right now, I tried to put everything into one slide so we can discuss and move forward, but you may have a lot more information in the tabs when you click on them in the actual exam. Okay, so when I talk about tabs, this is what you're going to see. This is probably one tab here, one tab here, one tab here, like nurses' notes and stuff, and one tab for vital signs. So all those things can come as different sessions. Make sure to, click on them and read them. All right, so now I hope that you have that patient in front of you. Just try to picture that patient who is a classic schizophrenia client, started on medications, and this is what is going on right now. Okay, just have that in your mind, because we are going to go to the first question in the unfolding case study. And for everyone who is getting case studies, unfolding case studies, okay, there will be standalone case studies which are different, which means you will have a lot of information, but there will be only one question or 2 questions, and that's it. But this is unfolding case study, which will have 6 questions, okay? So the first question is always going to be recognizing cues. Okay, this is where you will have the question where they are asking you, what are something which you will be concerned about? Or what are the things up here which you are like worried about? What is something which need your immediate attention? Those kind of things which will be recognizing the cues so that you can figure out what's going on. Okay, that will be your first question in the unfolding case study. Now, it can come in different formats. Okay, it can be a highlighting option. It can come as drag and drop. It can come as multiple choice. It can come as select all that apply question. So it can be any way the question is formatted, but the question will always be recognizing cues. So for now, for us, there is a select all that apply question. So which finding should the nurse identify as requiring immediate action? Select all that apply. Okay. So there's muscle rigidity, temperature, patient is withdrawn, diaphoresis, decreased oral intake, minimal urine output, auditory hallucinations. So out of all 7, Which findings should the nurse identify as requiring immediate action? Please don't jump into answers. Take your time going through them. It's a select all that apply question. If you make mistakes, you have negative marking. So we don't want to do that, right? So don't jump into actions. Think about it. I'm going to show you the scenario one more time so that you have a clear idea of what's going on and what is something which requires immediate attention from you. Okay, so we know the patient, what's going on, and now we have the options. All right, I'm going to give you a little bit of time because one thing I have seen in many of the students, when you fail the exam and you have given us your, your CPR, which is your performance report, candidate performance report, that's what it means. The report which you get if you fail the exam. So many people fail or below passing standard in this first session, in the first question of the case study. You are, many of you who are, you feel like you really know the case, you feel like you know the nursing content, but we have seen so many performing below passing standard or near passing standard for the first question. If you have ever written the exam before, go back and look at your CPR, the one which gives you how many questions you appeared, how was your performance. Look at it and go to the last 6, 7 areas. First one is going to say clinical judgment, and then it will say recognizing cues. That's what we are talking about. So if you are below passing standard or near passing standard in that, this is where you messed up. Okay, so take your time to do that. All right, so let's get into it. So which findings should the nurse identify as requiring immediate action? Now, what does that tell me? What is something I should be worried about for this case? Should I be worried about everything? Yeah, but that's not the question. It is asking requiring immediate action. So I need to figure out of these 7 things, what is something which is expected, or I know it's going to happen, or it's been always been there with this client. So is that going to be something which is immediate concern for me? No, right? So what is going to be the immediate concern for me? Something which is new, something which tells me there is something is going on, which was not there before. That's the one I will be worried about. Definitely, I am worried about muscle rigidity, right? I mean, I'm so thankful for all of you guys who are answering the questions. That means you're putting the effort, you are putting it together, which is awesome. So let's talk about muscle rigidity. Was that there when the patient came? I mean, was that something which is part of schizophrenia? Do we expect muscle rigidity as part of schizophrenia symptom? No. So am I worried about it? Definitely yes, right? That will be something I am worried about. So I will say muscle rigidity is a problem. The second one, temperature. Let's look at the temperature. Do we expect the patient with schizophrenia to have 102.6 degree? Like, no. So definitely that's going to be something I will be worried about, right? One of my immediate concern. Withdrawn, is that something I would see with people with schizophrenia? And the answer is yes. So is that going to be my requiring immediate action because the patient is withdrawn? No, that is not going to be something I will be worried about at this moment, because it could be part of that, psychiatric problem which the patient is having. Therefore, assess, is that something which I expect with a schizophrenia patient? No. So is that going to be a problem which require immediate concern from me, or should I do something about it? I mean, am I worried about it? Yes, I am worried about it, right? So diaphoresis, definitely yes. Decreased oral intake. Would you see that with the patient? That's something which the schizophrenia patients may have, right? Decreased oral intake. And since admission, So is it something new? I mean, is that something which happened? Because no. So is it I will be worried. Yes, I am worried. I need to make sure that the patient is getting enough fluids, enough, nutrition. That is one of the concern I would want to treat. But is it something immediately I need to recognize as something which is going on, something really bad going on right now? No. So decreased oral intake is not going to be my answer. Okay. Now, client had minimal urine output overnight. Okay. That is new. That is new. Okay. Now, I might be thinking, oh, but they have decreased oral intake. So what do you expect? Well, it could be, but it could also be something else because this is something new. And I am worried about that minimal urine output overnight. Okay. So is that clear how we are recognizing the cues? So what is going to be our answers here? 1, 2, 4, and 6. Now, auditory hallucinations, that is also something I would say, which is, it was there already. The patient actually came, if I look at here, the patient was there with auditory hallucinations, commanding them to stay alert because, more like paranoid too, and they're hearing things. It was already there. Is it something new? No. Okay, so that's why it's not going to be something I will be requiring immediate information or immediate concern right now. Right, so are we clear about how to critically think and eliminate some of the options? Because recognizing cues is going to be always going to be your first question in case study. Now, the good thing about it though, about the case study is that even if you mess up the first option or the first question or any question in those 6 ones, if you mess up one, it doesn't mean that you fail the case study. Okay, you will. That's why they give you at least 2 more, right? So it's not like if you didn't get the first answer right, because you might come to know in the subsequent questions, you might come to know that, oh, this is not what you're thinking and you made a mistake. And sometimes that happens because we get more information as we go through the case study. But don't panic. Even if you made a mistake, don't panic. Just focus on the question you have in front of you and do your best. Okay? Because worrying about the one which we already submitted is not going to help us. Okay, so it's very important to remember that. Okay, so let's go to the next one. Now that we know that, the unfolding case study 2, step 2 is going to be analyzing. Now, this is where, like I said in the beginning, this is where you might see an additional tab and you click on it and it gives you more information, right? So don't miss looking, rechecking every time. Every time you go to the next question in the case study, the second question out of 6, third question out of 6, make sure to go back and check on that tab again, all right? So this is step 2, analyzing, and this is where you clicked on it and you got a lot of lab studies here now. Okay, the nurse notifies the provider and obtains additional lab results. Now, the client condition continues to worsen and there is lethargy and not much verbal response, but this is what you have. Now, remember in NGN, you will be getting the normal values too, right? So we will have all those information available. So I want you to look through this and just have an idea, because the question is coming, okay, on analyzing cues. So I know there's a lot of information. You can even take a little note somewhere so that you know what's going on. Okay, the same case we are talking about. All right. All right, so you got an idea of what is wrong. I'm not saying anything because I want you to see the question. So this is what it is asking. This is analyzing the cues, okay, the second option. Based on the clinical presentation and lab finding, which interpretation by the nurse is most accurate? Number 1, the client is experiencing dehydration with electrolyte imbalance. Okay, so This is the lab value. Second, the client has developed an infection due to agranulocytosis leading to multi-organ damage. I'm showing every time the lab value so you can connect. The findings suggest neuroleptic malignant syndrome. For the client is developing tardive dyskinesia due to adverse effect of the medication. So we have 4 options and what's going on. That is the question. Okay, I know it's I'm glad that you're thinking. All right, now we are thinking what's going on with this patient, right? Let's get back to the initial scenario which the patient was having. So let's get back to here and then just think about what is going on with the patient. Which medicine is the focus here? What is the focus here? Patient had schizophrenia, all the symptoms was getting worse. So what did we give? We gave haloperidol. That is the main thing which this entire case today is going to focus on. Yeah, haloperidol. Now, we did talk about this in Wednesday pharmacology session. You have this available in your course about this medication group. Now I'm going to show you something. Well, before I go into that, can you tell me what kind of medicine is haloperidol? Which group of psychiatric medications do they come into? Is it like SSRI? Is it SNRI? Is it a TCA? It's an antipsychotic. Yeah, very good, very good. It is an antipsychotic medication. And in our class, this is something I have used, that they are antipsychotics, and there are 2 kind of, we said, generations, first generation and second generation. And this one is a first generation, and this is what we said we can probably remember. Chlor had fluperthio, right? Chlor had fluperthio. So chlor is chlorpromazine, had is haloperidol, flu is fluphenazine, per is perfenazine, and we have the thio, which is thioxetine. So those are the medicine, and then hal comes here, haloperidol comes here, right? And what else did we learn with this antipsychotics? You have this entire video available to you in pharmacology, okay? Or pharmacology or mental health, you will see them. So in this one, what is something we specifically talked about between first generation and second generation? That was higher risk for adverse effects. They're really good medicine. However, higher risk for adverse effects. Now, what are the adverse effects we are talking about when there is antipsychotics? And they are EPS, which is what is EPS? I hope you remember EPS. There are so many things in EPS. There is dystonia, there is Parkinsonism, where there's all these gait problems. There is akathisia, where they are not able to stand or sit, or they're restless, they're pacing. And there is tardive dyskinesia, right, which can be like involuntary movement. So that's something which is there, right? So that's one problem. We know EPS is something which can happen with antipsychotics. Second is neuroleptic malignant syndrome, and we had an entire discussion about that. Then there is anticholinergic symptoms, which is like drying, right? Everything is dry. And there can be neuroendocrine effects like weight gain, and diabetes can happen. I mean, all those kind of problems which could be more related to endocrine effects. So those are the higher side effects which might be happening. Now let's look at the question we have. So if this is about haloperidol, which one can I eliminate? Can I eliminate one? Because I don't think it's just dehydration with electrolyte imbalance, right? Yes, there is imbalance, right? I know the sodium is little off and the potassium is up. And what else do I see? What is something which is like striking me? The moment I see this, I'm like, what is something really, really bad? What will I be really worried about? I see the CK, which is like 12,000, right? So dehydration doesn't explain that much. And then I see the BUN is kind of high. The creatinine is kind of high. The liver enzymes are bad. And there is urine, definitely there is dark and positive, and the CK is high. And look at the WBC level. It's 11,500. And our cut mark, the high is 11,000. So not too bad. So I know it's not probably one. I mean, it says most accurate. Okay, I'm not saying that they don't have any electrolyte imbalance. There is electrolyte imbalance, but this is not a selector that apply question. We have to select only one, which is most accurate, focusing on the medication which is given, right? So I would definitely take out the first one. It's not specific, and there is more in the lab value than just an electrolyte imbalance. So that's not going to be the most accurate for me. And it has no direct relation between the antipsychotic medication. Okay, how about 2? Was there anything we said about haloperidol or the antipsychotics like first generation antipsychotics? Was there something which is causing agranulocytosis? Okay. And do we have any information here about agranulocytosis? What is agranulocytosis? Your WBCs, your neutrophils will be low. But what is the WBC here? It's kind of there, right? I mean, it's like 11,500. I mean, not within the normal limit, kind of a little bit of towards high. So do you think it's an infection from agranulocytosis? No, right? And not only that, if it is an infection, it doesn't explain the other thing. Okay, multi-organ damage, I'm like, maybe because liver enzymes are elevated, kidneys are elevated. So that could be there, but this doesn't make sense that much. Which is the medicine which we are like, agranulocytosis and like captopril and, there are some medicines which are like, we know they create olanzapine. There are some medicines we know we are kind of worried about it. Okay, but not in this one, right? I mean, do you get my point? Because that's how we eliminate. Now, this is where you will feel like, just like Neha said, it's like blank because everything seems like a fit to the question. And you will get those kind of things. I mean, it's not going to be easy, but we are smarter. We know how to think, and we are going to connect those information we have learned from our course and apply it here so we can eliminate options. Okay. All right. So we are going to eliminate that. Now, how about tardive dyskinesia? Can antipsychotics cause tardive dyskinesia? Answer is yes, because that's part of the EPS, so it can cause tardive dyskinesia. But what have we learned about tardive dyskinesia? What is something which is going to help me eliminate tardive dyskinesia? There are a couple of things. One, it is a late symptom. It doesn't come when the patient takes haloperidol for like 2 days or 3 days. All right. This is something which you will see when the patients were on this medicine for a long time. And that's one thing. Second thing, the movements are not about stiffness and fever and CK is elevated and creatinine is elevated and BUN is elevated. And that doesn't come with tardive dyskinesia, right? It's totally different. Do you get my point? Even though it is possible It is part of the EPS. It can happen with antipsychotics. But because I am able to recognize what it is, and it's not that this is where some students will be having difficulty, because all they know, especially someone who thinks they are really good with theory, they will think, oh, antipsychotics, I know antipsychotics, and there is EPS, and tardive dyskinesia is EPS. That's all they know. But we know better, right? We know that there are something very important. We need to have an in-depth information on what exactly is it. Number one, it doesn't happen all of a sudden. Takes time. Second thing, the movements are different. Third thing, the lab values doesn't change because of tardive dyskinesia. Okay, does that make sense? So I am going to eliminate tardive dyskinesia here. So in that case, I think you all know what is the answer, because the next answer which we have here is number 3. Okay, the findings suggest neuroleptic malignant syndrome. Now, I don't want to show you the neuroleptic malignant syndrome slide, which we have used to learn about, because some of my questions are part of it. So, but we know what it is. I'm going to show you the rationale though, right? Because neuroleptic malignant syndrome is where there is fever, right? And there is severe muscle breakdown. That's a characteristic of the neuroleptic malignant syndrome. And that's when the CK gets elevated because of the muscle breakdown, right? And then what's going to happen? There is going to be rhabdomyolysis, right? And there's myoglobin in the urine, and BUN and creatinine explains that, right? And potassium could also be related to this, right? So there is things going on which we know, which are very, very important in diagnosing the issue. Okay, so we did have all these talks about neuroleptic malignant syndrome in the class. Please do listen to that video, okay? So very, very important. Okay, so this is where we did our analyzing the cues. That was the second question. Are we good? I'm going to move on because we have lots of things to work on. If anybody is feeling behind because you don't know what neuroleptic malignant syndrome is, don't worry, just go to the pharmacology session or the mental health session and learn about it, and you have everything you need right there. Okay, all right, so let's go to the next one. This is where we are going into step 3, or the question number 3 of this unfolding case study, and it will always be for you a priority answer. Okay, so this is the priority. The provider has been notified and the client has been diagnosed with neuroleptic malignant syndrome. I'm going to use NMS from now on, but you know what that means, right? Neuroleptic malignant syndrome. So what potential complication is the priority for the nurse to monitor in this client? Okay, which potential complication is the priority for the nurse to monitor in this client? Number 1, acute tubular necrosis secondary to rhabdomyolysis and myoglobin release. Number 2, worsening psychosis with increasing auditory hallucinations and paranoid delusions. Number 3, severe malnutrition with dehydration due to prolonged refusal and of oral intake. And number 4, suicidal ideation with a stated plan to harm self. So what would you say is the potential complication? Yeah. Okay, I see some of the answers coming. This is something I would like you to remember. When you are in an unfolding case study, you are going to stick with what you have already decided or analyzed, okay? Now you know that the patient has neuroleptic malignant syndrome. What is the focus of the case study now? Neuroleptic malignant syndrome. Okay. What is the question asking? I mean, that's why it says here again, the provider is notified, they did what they need to do, and the doctor has been, informed, and the diagnosis is made. It's neuroleptic malignant syndrome. Stay with that, right? With that, which potential complication, read the words, which potential complication is the priority to monitor? In a simple wording, a patient with neuroleptic malignant syndrome, what is the potential complication I should be worried about? Does that make sense? Right? I think that makes sense now that I am explaining and breaking it down a little bit more. I see that it's making sense. So what is the answer here? 1. Okay. What is the problem we are focusing on? Neuroleptic malignant syndrome. What does it do? What is happening with neuroleptic malignant syndrome? Breaking down, right? Muscle breakdown and autonomic instability. We saw that the patient's heart rate was high, the blood pressure was high, the temperature was high, and the patient was stiff. All those things, and we know the lab value. We know the lab values. So what is that telling us? The patient might go into acute tubular necrosis. What does that mean? Acute tubular necrosis. What is that? What tube are we talking about? Which tube are we talking about? Or which organ are we talking about? That is kidney. Yeah, that's kidney. Tubular necrosis is the kidney problem. So we are talking about the kidney failure, kidneys having trouble. Because all this rhabdomyolysis, we already saw that the creatinine is high and BUN and everything is getting there. So that's what we are worried about. That is a potential complication. Right now, it's in the beginning stage of acute kidney failure. But if you don't take care of it, it will go into necrosis. That's a potential complication, necrosis, okay, which is the most problematic one. Okay, now why not 4? Why not 4? Is neuroleptic malignant syndrome going to cause suicidal ideations? Answer is no. Is suicidal ideation one of the hallmark of schizophrenia, or is it the hallmark of major depression? It's more with major depression. Is everybody with auditory hallucination is going to kill themselves? No, because auditory hallucinations can be a variety of stuff. When it is a commanding, or thought insertion, commanding, those kind of hallucinations are the ones which might make the patient jump from somewhere or harm themselves or harm somebody. Okay, so I mean that could be problematic. But is that the focus? No. Is neuroleptic malignant syndrome is going to make them suicidal? The answer is no. Okay, and remember, this is not right now happening. I mean, we are not talking about the patient is having a stated plan to harm himself. No. That's not it. Okay, this is not happening right now. What is the question saying? Potential complication. Now, if let's say the question says, or the option says, the patient is telling that they are going to harm themselves, of course, that's going to be a priority. Okay, we are worried. But that's not what the system is saying right now. Okay, I hope that makes sense. Okay, Purnima, thank you. And this is why I didn't want to say much, because I didn't want to give away the answer, but I hope that helps. Okay, so, all right. Now, this is also something which can happen, if the patient does not eat or drink or look at the nutrition, then it is a potential complication. But what is the priority for neuroleptic malignant syndrome? That's this one. Okay. All right, so 1 is going to be the answer. And just in case you need to look back at it, I'm just keeping the rational explanation here, okay? All right, so now we are going into the 4th part in this case study, which is going to be generating solutions. So thank you, there is generating solutions. And this is where you will get questions like planning kind of questions, okay? Like appropriate, not appropriate, or anticipated, not anticipated, or it can be a select or that apply question too. So here we have one which is like anticipated or not anticipated. So this is what. So what is, what are the things which you would say are anticipated and what are the things you would say is not anticipated? Like the nurse is, getting all these orders and prescriptions and what do? We know it's neuroleptic malignant syndrome. We know that now. So what is something we might be doing? Let me know what is the anticipated ones. Okay. Number 1 is discontinue haloperidol. Number 2, administer dantrolene. Number 3, institute seizure precautions. Number 4, encourage ambulation. Number 5, administer IV fluids. And number 6, initiate cardiac monitoring. Just let me know what are the anticipated ones. Anticipated ones. What do you think? All right. Okay, so let's do it. Let's do this. Before that, now I can show you about our slide from neuroleptic malignant syndrome. And the reason why I don't wanted to show this before is all this information is here, and I didn't want to just give you the answer just like that without thinking. So that's why. So we know this patient is already, neuroleptic malignant syndrome patient. What do? We discontinue the medication. So definitely discontinue. Yes, we don't want to keep giving that. So we have to discontinue that. And we know there is a fever problem. So we will be giving IV fluids. We will be giving, hydrotherapy, cooling blanket, seizure precautions, right? Because it can go real bad with the muscle stiffness and rigidity and high fever and then autonomic dysfunction, like the patient was having diaphoresis, tachycardia, hypertension, I think tachypnea too, right? So all these classic neuroleptic malignant syndrome, all these problems were there for the patient. And high CK, right? So what do we do when there is high creatinine kinase, rhabdomyolysis? Lots of fluids again, and muscle relaxant. And our dantrolene is a muscle relaxant, which can be used. And we will have cardiac monitoring because the patient can end up with dysarrhythmias, right? So now that we know about this neuroleptic malignant syndrome, that there is all this problem which will happen, and this is how we will manage it. Let's go back, and what is going to be our answers now? Let me show you the answers. Discontinue haloperidol, yes. Administer dantrolene, yes, because it's a muscle relaxant and it's good to do that. Seizure precautions, yes, obviously. Do we want to ambulate the patient? No, this is not the time to ambulate. The patient is not stable, right? There's having a lot of kind of life-threatening problems going on, and ambulation is not the right time to do it. IV fluids, yes. Cardiac monitoring, yes. How do we know all these things? From here. All right, are we good? So we can, if you know this much from neuroleptic malignant syndrome, you will be able to answer most of the questions. Okay? Good job, good job. We are making progress, right? You're good? Just making sure that you all are understanding it. Yes, okay, good, good. That feels so good. Okay, let's go to the next one then. So we did 4. Now we are going into the 5th question, which is taking action. On this one, it's a little bit more information. And this is where you will see a new tab. So you have been reading all these things. Okay. And then there is like the 5th question, there's a new tab. And now we have to make sure that we click on the tab and read this, right? So it says the client is diagnosed with neuroleptic malignant syndrome, which we already knew. Haloperidol is immediately discontinued. Good. The provider initiates IV fluids. Yes, we know that's needed. Medications to manage autonomic dysfunction. Okay. What is that? What is that autonomic dysfunction? Autonomic dysfunction? the diaphoresis, the tachycardia, the hypertension. I mean, autonomic nervous system is the things which we don't have control over. I mean, in our heart or our breathing and our sweating and all those things. Okay, that's the autonomic. So the doctor ordered some medications to take care of all that. All right. What else do we know? Muscle relaxant, cooling measures. So it seems like they are doing all the right thing for this neuroleptic malignant syndrome. So over the next 2 hours, the client's temperature began to come down. It's like not normal yet, but 101.4. The client remains rigid but minimally responsive. Urine output remains low at 20 ml per hour. That's low. And urine continues to appear dark. Okay, blood pressure is now 92/58. Well, it did come down, and heart rate is 124. A Foley catheter is in place, and repeat labs are pending. So maybe they need to know about, how the CK is, how the kidney functions are, they're trying to get that. The client's family arrives in the unit. They're anxious, asking multiple questions. Of course, they will be worried, right, about the client's condition and prognosis. So things change, right? This is like after 2 hours we are talking about. Now the question, which action should the nurse take next? Number 1, allow uninterrupted rest to the client and reduce stimulation. Number 2, provide detailed education to the family about neuroleptic malignant syndrome and treatments. 3, delay interventions until repeat lab results are available, because we said repeat labs are pending. Number 4, increase the rate of IV fluids as prescribed to promote renal perfusion. So we have 4 options here. Now, this question is about action. What do you do, right? It's about the action. Now, in that, what is the information you are going to focus on? This information which is given. Okay? We know the patient is neuroleptic malignant syndrome. We know we have already notified the doctor. We stopped the medicine. We started all the right things to take care of this patient, right? And we have the information here now. Yes, there is this family now coming. What do we do? All right, I am so happy to see that you all are getting the best option available. The number 1 thing I am going to eliminate is going to be 1. Allow uninterrupted rest. This is not the time for uninterrupted rest. Okay, I don't want to create a lot of stimulation because I know the patient is, seizure precautions and all those things, but I need to keep checking on this patient. I cannot just let him know, you sleep now, I will come back later. No, this is an emergency kind of situation, right? I will be taking vital signs frequently. I'll be checking, pupillary reaction. I mean, and all those kind of labs and assessment. I cannot just let them be uninterrupted at this moment, right? Now, that doesn't mean that I can just let all the family come and, do all the anxiety stuff. No, I don't want that either. I might ask the family to wait outside or in the, some place where they can sit comfortably, or maybe I can ask the doctor to come and explain to the family about what's going on. So that's there, but it can wait. It says like, what is the important thing I should be worried about right now? I don't want to delay interventions either. So that's the 4th one is going to be the best option. Now, why am I so concerned about that? Because the patient is not that better yet, right? Still has fever, still remaining rigid, minimally responsive, oliguria. I mean, urine output is like 20. Urine is still dark. And on top of that, the patient is hypotensive, going into hypotension, not that bad yet, but 92/58, and tachycardia. I don't like that combination, right? hypotension, tachycardia is something we are always worried about. Okay, so what is something I can do to help with all that, right? And that's going to be the fourth one, right? So are we okay with that? You good? The most important thing is to prevent organ failure. And one of the problem we said, acute tubular necrosis, right? The kidneys function can shut down and we don't want that to happen. So what is something we can do out of these four options to help with that? Keep up the IV fluids, right? So are we okay with that? The explanation. So I hope that's clear. Right. Okay, now the last one. We are going into the sixth question, which is about evaluating the outcome. Okay, in that time, we have a little bit more information now. It's been 48 hours. So after this treatment and stuff done, and we discontinued the medicine, we did the IV fluid, we did the muscle relax, and everything is done. And the client, thankfully, the client is more responsive, able to follow command. Muscle rigidity is decreased significantly, but diaphoresis is still there. Temperature is 99, right? Heart rate is 92. Blood pressure looks good. Urine output 45, and urine is now kind of lightly low. So it's like about 48 hours into the treatment. And we still have some lab values. The CK is 1200 and creatinine is 1.2. Now, what was the early CK? The earlier lab which we had, CK was 12,000 and creatinine was 1.9. So from 12,000, it is now 1,200. Oh, that's really good. And creatinine is also getting there better, right? 1.2. Okay, now the question. Which finding indicate that the client is improving and the treatment is effective? So select all that apply question, and we are looking for something good. We're looking for things which tells us that the patient is getting better. Okay. What are the better things here? Just select all the better things where you know that it is getting better. Treatment is effective. Okay, one, definitely yes, decreased muscle rigidity, which means the patient is getting better, right? Client is improving. Treatment is effective. You know, it might take some time, but it is improving. So decreased muscle rigidity, that's yes. Urine output 45, I would say yes, because it was 20 something and it's getting better. Creatinine kinase, yes, because it was 12,000, now it's 1,200. This is not there yet because still the autonomic dysfunction is still there. That's why they are still diaphoretic. But the temperature is good, right? So we will go with that. I think many of you got that option. So 4, we are not selecting that because they still have diaphoresis. Okay. Swapna, I think you are the one who said that. So just make Siji and Swapna, we are not selecting 4, okay? Because persistent diaphoresis means the autonomic dysfunction is still there. Now, why am I saying autonomic dysfunction? Because we know from our information on neuroleptic malignant syndrome, see there, its diaphoresis is autonomic dysfunction. So they're not ready there yet. Still some problem. Might get better, but it's just been 48 hours. All right? Oh, okay, okay. But don't do the mistakes in the actual exam. Here you can make mistakes, no problem. This is your safe place to make mistakes. Make them, no problem. We'll figure it out. But in the exam, be careful. Okay, all right. So we are now, well, that is the last question on the sixth one, right? So that's where the evaluation comes. And you might get questions where it's like there are tables and then you will be, clicking on whether it's improving or declining or something like that. So it can come in any format. All right. Okay. All right. So that's all about neuroleptic malignant syndrome. Now, if you get any question on neuroleptic malignant syndrome, you should be 100% ready.